Hmm. So I could just move this.
Hello, everyone. Thank you for joining us today. We are excited to have you with us on this extremely important webinar entitled Advancing Equity for Muslim Physicians in the Healthcare Workforce, a collaboration between the Initiative on Islamic Medicine, Medical College of Wisconsin, and the Tanenbaum Institute. And so we're really excited to be discussing a topic that has to do with an upcoming research paper that we'll be sharing with you all soon and shortly as well. And so with that, I'd like to just do a quick introduction on who the Initiative on Islam in Medicine is and who are the folks behind it as well. So really the Initiative on Islam in Medicine started off as a research arm and at the intersection of Islam and biomedicine, and producing scholarship really that impacts the lives of Muslim patients. And these experts come from a cross-discipline of theological, social, and biomedical sciences, and really for two aims in terms of the deliverables that we aim to achieve. The first being improving the health of American Muslims and really looking at health behaviors and healthcare experiences being shaped by faith, and really mobilizing that knowledge towards an evidence-based and culturally tailored health intervention and policies. The second is really to develop an academic multidisciplinary field of Islamic bioethics. And so that's really closing the gaps on the literature and really looking at theologically rooted normative goals and disciplinary parameters of the field as well. And so this is really to assist Muslim patients, clinicians, chaplains, and imams to engage with modern medicine faithfully as well. So really, who is II&M and the board of directors? I myself, my name is Adil Sayed. I am the CEO of Ummah Community Clinic, the first and largest federally qualified health center founded by American Muslims in South Central Los Angeles. But we also have some distinguished colleagues, one of whom will obviously the main author of one of the authors of today's report that we're discussing, Dr. Asim Padella. We have Dr. Najim Fasuddin out of Florida. We have Fatima Mirza, who's a community organizer out of the Chicagoland area. Second row, we have also Dr. Faisal Qazi and Dr. Sundus Al-Saad. So all of us come from various backgrounds and disciplinary practices, and we serve on the board of directors for II&M. Wanted to share briefly some of the projects II&M has been working on. Initially, really, it was around the National Survey of Muslim Physician Attitudes towards Religion and Medicine, engaging Muslim Americans research on community health, or eMarch, a project that was done with collaboration with community organizations, in addition to PCORI, the Patient-Centered Outcomes Research Institute, developing a religiously tailored mammography intervention for American Muslims, work around organ donation, American Muslim health and spiritual needs as well. One of the interesting topics that we looked at during the eMarch conversation, and Dr. Padella can attest to this, is when we were sitting in front of HHS and Health and Human Services and other national folks, there was the question of, well, what are important areas of Islamic bioethics, Muslim healthcare, issues around discrimination, and what are kind of the top 5 to 10 areas of top health concerns for American Muslims. And so as part of the eMarch cohort, I think we identified some of those. I think, I'm not sure if there's one more, I think, infographic that shows the 10 top health concerns for American Muslims as identified by a cohort of interdisciplinary postdoctoral fellows, graduate students, who then took on these ideas and kind of started their own research as well to really create the gap of healthcare literature that exists in the American Muslim community. And so that was really the aim of that project and many of the projects that II&M has taken on. And so really looking at II&M's goals, visionary research and education to practical outcomes, and far more than just being a think tank or putting out reports that are going to be of no use. Really, II&M's goal is to design religiously tailored, evidence-based educational programs that the community can really look to for empowered, informed, ethical decision-making, whether it be end-of-life care, organ donation as well, other topics that were previously discussed. The second area was to really develop policy recommendations that incorporate Islamic values and meet Muslim patient and clinician needs. Part of today's discussion as well in terms of discussing the needs around Muslim clinicians in the workforce as well. And I think thirdly is to really generate a generation of clinicians, chaplains, other healthcare leaders that are literate in the Islamic tradition as well as modern medicine. I think this crosses the lines of whether folks are from the Muslim faith or outside the faith tradition, to really make sure that there is a culturated understanding of some of the needs in this community. And so lastly, I wanted to just share this slide and share the kind of the nexus of the intersections that II&M has really done work in. So these four nexus, so whether it be policy stakeholders, the healthcare system, academicians, and the Muslim community, and it's to really focus on data-driven, culturally and responsive healthcare and create a synergy in order to make sure that the information necessary to engage these communities is backed up with both the research and the appropriate on-the-ground implementation and execution strategies that will be best of practice. So last but not surely not least, I'd like you to invite you to visit medicineandislam.org for more information. Specific areas that we are focused on are community workshops, consulting around Islamic bioethics, courses and certifications, research and training, as mentioned previously, medical student internships, and other tools and toolkits that are available for you to take a look at in order further into this work. So thank you again for joining us. And with that, I will pass it on to Madeline.
Thank you so much, Adele. And hello, everyone. And thank you for tuning in today. Welcome to Advancing Equity for Muslim Physicians in the Healthcare Workforce. Again, this webinar is brought to you by the Initiative on Islam and Medicine and the Medical College of Wisconsin in partnership with the Tanenbaum Center for Interreligious Understanding. My name is Madeline Frankel, and I'm the Senior Healthcare Program Associate at Tanenbaum, and I will be moderating today's conversation. For those of you who may be new to our work, Tanenbaum is a secular, non-sectarian nonprofit based in New York City. Our mission is to promote justice and build respect for religious difference by transforming individuals and institutions to reduce prejudice, hatred, and violence. As a secular, non-sectarian organization, we do not promote nor denigrate religion. Rather, we recognize religion as a powerful force in people's lives, and we address it as such in our 4 program areas: within workplaces, among conflict zones through our peace building program, in healthcare settings, and in educational systems. Today's webinar marks the culmination of several years of research conducted by Dr. Asim Fadela and his team. The resulting landmark policy report will be made available on medicineandislam.org in the next few days. During our time together, you will hear from several expert panelists who will describe the Muslim American population in the current socio-political climate surrounding this community, review the impact of religious discrimination on the professional and psychological outcomes of Muslim physicians, and finally, we will discuss ways to advance healthcare workforce equity and build cultures of religious inclusivity. I also want to note that we will reserve the last 30 minutes of our time together to answer audience questions. So please feel free to type and submit your questions in the Q&A box, and we will most certainly do our best to get to all of your questions during our last 30 minutes. I now would like to welcome our first panelist, Mehra Nagaz. Mehra is the Executive Director of the Institute for Social Policy and Understanding, an applied research and education organization that studies the challenges and opportunities facing Muslim Americans. Before joining ISPU, Mehra worked as a global public health professional, leading health organizations and programs in Latin America and around the globe for more than a decade. In her early career, she served as a caseworker at the Big Brother Association and as the director of a private foundation. Mehra holds a BA from Huron University, a Master of Arts in Law and Diplomacy from the Fletcher School of Law and Diplomacy, and an International Health Certificate from Boston University. She additionally studied public health at Johns Hopkins University School of Public Health as a non-degree student. So Mara, the floor is now yours to give us a snapshot of Muslim Americans and review the need for religious accommodations in the workplace.
Thank you so much, Madeline, and thank you to Tanenbaum and to II&M for inviting us here today for this important discussion. As Madeline mentioned, I wanted to start by just providing a snapshot. Who are American Muslims? What does this population look like? What are some of the lived experiences that could have bearing on Muslim American experiences within our healthcare system, and really just help set the stage and provide some context for the findings that we will hear about in a little bit. Much of the research I'm going to share with you today is drawn from ISPU's own research, although I will pull in some other research where noted. So let's start with some demographics. Just who are American Muslims? Now, there are no 100% accurate numbers of how many Muslims are in America, but the best estimates I think that we have come from the Pew Research Center from 2017. And Pew estimated that there were 3.5 million Muslims in the United States, so making up just over 1% of the total US population. Because religion is not routinely asked on the census or in many other places, it is impossible to get an accurate count. But Muslims have been part of America's faith landscape for centuries, since before our country's founding. Scholars estimate that approximately 1/3 of enslaved people were in fact Muslims, and Muslims came early on as diplomats, and then of course in subsequent waves of migration. But what does this population look like? Who are American Muslims? Muslims are the most diverse faith group that we studied. And you can see from the pie chart that there's no majority race or ethnicity. So about 14% of Muslims identify as Arab, just under 20% as white, and just around a quarter as Asian, nearly a third as Black, and about 8% as Latino, 2% as Native American. So it is a very, very, very diverse population, and people often have overlapping identities. It's also a young population. Just over a quarter of Muslims are aged between the ages of 18 and 24. So it's really important for us to lay the groundwork for a better tomorrow for these young people who are reaching adulthood. And while half of Muslims in America were born advance the slides, please. The next one, yeah. While half of Muslims in America were born outside of the country, just under 90% are in fact American citizens, either by naturalization or by birth. Now, despite the relatively small size of Muslims in the country at just over 1%, Muslims play a really important role in the medical field and in our healthcare system. We know from our research, for example, just looking at the state of Michigan as a sort of case study, that Muslims, while they make up just under 3% of the Michigan state population, more than 15% of the licensed medical doctors in Michigan are in fact Muslim. These Muslim doctors provide roughly 1.6 million patient appointments every single year, and create just under 40,000 jobs that are supported by Muslim physicians. Additionally, 10% of the pharmacists in Michigan and 7% of the dentists in Michigan are in fact Muslim. But Muslim doctors are not simply practicing medicine. They are often responsible for making significant innovations and improvements across the entire medical field. One example of that is Dr. Mahmoud Hai from Michigan, who was a pioneer and leader in developing green light laser technology, an innovative treatment option for men with enlarged prostates. And as was mentioned before by Adil, Muslims also provide a lot of charitable medical care. The Clinic was one that he mentioned. Another is the Huda Clinic in Michigan, which with more than 50 providers provides free care to more than 1,400 patients. We've seen similar patterns to this in our case study in New York City, and no doubt most likely nationally. So meeting the needs of Muslim physicians and providing an equitable, non-discriminatory workplace is really, really essential, not just for the individual Muslim physicians themselves, but for our healthcare system. Unfortunately, what happens inside hospitals and medical facilities is these places are microcosms of what happens outside of them. So as we think about the findings later presented, we need to look at them with a little bit of context. Now, anti-Muslim sentiment, discrimination, prejudice, or bias, whichever phrase you would like to use to describe this, it can take many, many forms, from blatant physical violence to hate speech, to microaggressions, stereotyping, and literally everything in between. And this type of bias is really a branch on the tree of isms. It's interconnected with racism, anti-Semitism, and every other type of bias you could imagine. And some of our research shows the links between all of these types of bias and discrimination. So very similar roots. It would take a whole session to talk about what those roots are. But to name a couple, many Americans have never knowingly met a Muslim. And that can, lead to stereotyping and just misunderstanding. The media, while I am a total media junkie myself, studies have in fact shown, one notably by Media Tenor, that the media in the United States does largely focus on negative things about Muslims, if at all. And political rhetoric, which we've seen very hotly in the past 20 years and sometimes before, really heats up and uses Muslims as pawns, often most notably around elections. So all of this can contribute to a situation where anti-Muslim sentiment is in fact pervasive in the wider society, and this can seep into our healthcare system and our workplaces. At just over 60%, Muslims face the highest rates of religious discrimination of the groups that we studied. This is self-reported discrimination. And this has remained pretty constant over the past 6 years that we have been tracking. So it's not been a blip, but really a rather stubborn problem that is hopefully not intractable, but it has been pretty steady. And the next slide. And this discrimination is both interpersonal and institutional. So it takes place between people in sort of informal interactions, but it also has been structural and institutionalized. And Muslims, according to our survey, are most likely to experience each type of discrimination. So, for example, 43% of Muslims experience religious discrimination when interacting with their coworkers. And again, this seeps into our healthcare system. In institutional settings, Muslims are most likely by far to experience religious-based discrimination when applying for a job, when interacting with law enforcement, when traveling through the airports, and really importantly for this conversation, when seeking healthcare services. Next slide. In fact, Muslims who say they've experienced discrimination in the past year, of those Muslims, 25% say it happened within a healthcare setting. So this is a problem in healthcare settings, and a quarter of Muslims say that they've experienced discrimination in that area if they've experienced discrimination at all. Now, the impact of this obviously may take a toll on mental health and anxiety of people experiencing these issues. So we know from our research that after the 2016 election, when there was a lot of heated political rhetoric about Muslims, that there was a significant amount of stress and anxiety and fear for personal safety. Most notably, almost half of Muslim women and more than 30% of Muslim men feared for their personal or family safety. And a sizable number, nearly 10% and nearly 20% of Muslims, Muslim women 19%, Muslim men 9%, felt stress and anxiety to the point of possibly seeking mental health support. Now, Dr. Muniba Salim also notes that groups who have been targeted or hear negative things about their group can internalize those negative aspects. And in doing so, this can have a huge effect on mental health, on self-esteem, identity, performance, and motivation. And in our own study of Muslim healthcare workers last year, where we looked at sort of a year into COVID, we examined psychological distress distress, discrimination, and sources of that stress, as well as coping mechanisms. And what we found is that 47% of the sample reported at least one form of discrimination during the period, including anti-Muslim bias. And this form of discrimination was associated with a higher risk of psychological distress, including depression and anxiety. So, for example, compared to those who did not experience discrimination, healthcare workers that experienced occasional or regular discrimination of mixed forms, so that could have been racial, gender, or religious-based discrimination, when compared to those who did not experience discrimination, they had 5 times higher risk of mild distress and a 9 times higher risk of moderate or severe distress. Next slide. Now, despite all of these challenges, Muslims are highly devoted to their faith. And Madeline mentioned this before, that faith can be a really powerful force in people's lives, and Muslims are no different. So 70% of Muslims that we surveyed said that their religion is very, very important to them. And this does not significantly differ across age groups. And 85% of Muslims say that their faith is a source of happiness, and a similar percentage say they're proud to be members of their faith community. Now, what we know from our healthcare workers study that I mentioned before is that people who, Muslim physicians and healthcare workers who experienced anti-Muslim discrimination in the workplace, they actually sought out coping strategies of a religious nature, including things like extra prayer. So accommodating Muslims who play a completely vital role in our healthcare system and for whom religion is really important is not only good on an individual level and should be done for that reason alone, but it also strengthens our healthcare system and ultimately, hopefully, provides better care for our Muslim and non-Muslim patients. So it's against this backdrop and this context that the findings presented today can be thought about and understood. And I look forward to answering any questions later on.
Mara, thank you so much for this insightful look and really laying out the foundation of Muslim Americans for us. And I'd now like to introduce our next panelist, Dr. Asim Padella. Dr. Padella is an internationally recognized thought and research leader in the fields of Muslim health disparities and Islamic bioethics. In addition to leading the initiative on Islam and medicine, he maintains an active clinical, research, and bioethics practice at the Medical College of Wisconsin. As a scholar, Dr. Padella's focus is on the intersections of healthcare, bioethics, and religion. Overall, his scholarship aims at improving health and healthcare through better accommodating religious values in healthcare delivery. Dr. Padella has authored over 100 peer-reviewed journal articles and book chapters, and 3 forthcoming books on Islam and biomedicine and ethics. Dr. Padella's expert commentary has been featured in multiple leading media outlets, including the New York Times, USA Today, the Chicago Tribune, the Washington Post, National Public Radio, BBC, and CNN. So I now invite Dr. Padella to share more about his team's landmark research in religious identity and in the healthcare workspace and Muslim clinician experiences in focus.
Thank you so much. It's a pleasure to be here with you all. And I'm glad that we were able to have a conversation. Thank you, Myra, for that great introduction. So as Madeline suggested, I'm going to take a deep dive into the healthcare workplace, and you have now a sense of what's happening outside of that. And before I begin, I would like to note that this is just not my work, it is the work of our large team. And most notably, I'd like to thank Leila Azim, who's not able to make this webinar today, but is the one that's organized all of this behind the scenes for all of us. So with that, let me sort of think about where we are at today in 2023. We're at a time where a lot of medical students are transitioning to resident life. They're moving from a student-protected population to now employees in a workplace. And oftentimes what they do, most commonly, this became a pandemic practice, is that they would announce on Twitter or other places that they're entering the field of medicine, what their interest in the specialty is, and they're looking forward to matching within a highly sought-after residency spot. So this is one individual. from emergency medicine, a field that I practice, who put this out on Twitter just a couple of days ago. The question that I'm going to try to answer for us today is, what will her experience be? Specifically, how will her patients respond to her? How will her colleagues treat her when she enters the profession? How will the workplace environment shape her? And what will her career look like? So we're going to try to forecast forward what this will be for this individual. But to do that, we must take a step back and look at what has happened in the past, right? So as one of my favorite authors, Shakespeare, says, past is prologue. So in 2016, a colleague of mine wrote a commentary about her experiences as a resident. So she spoke about this, and I'm going to highlight areas, given our time, that she was an individual. This is Altaf Saudi. She went to Harvard and Yale, and she thought that having done that sort of work, she would have a golden ticket to America's meritocratic dream. That training would shield her from experience of racism and bigotry. She actually went to residency at a very elite medical school, hospital system in Boston. But she describes a lot of experiences of racism, bigotry, and discrimination. So for example, a Maine patient told her that her religion is superior to hers, right? And saying things like, why do you wear that thing on your head anyway? Or she spoke about another patient who pointed to her headscarf and said, I don't want someone taking care of me. And that racism she carried with her through her residency training into her professional life. So the healthcare context, what we do know is that workforce diversity offers multiple patient level and societal benefits, right? It enhances communication between patients and doctors, builds stronger therapeutic alliances, provides for greater access to care for populations because they see people like them in the healthcare system, so they're more trusting, and it produces better outcomes in many different domains. We also know that religion strongly influences the practice of over 50% of physicians. They report that they carry that with them, or it's a calling, religious calling to be a participant in medicine. But we also know that significant numbers of physicians from minority backgrounds encounter workplace discrimination in a lot of national studies, some of which I'll share with you in a few moments. And that leads to negative outcomes, such as job turnover and career dissatisfaction. While we know religion strongly animates the practices of over 50% of the US physicians from national surveys, we know that DE&I, meaning diversity, equity, inclusion efforts, often overlook this religious identity of physicians when they make interventions. So we're going to change that. So here's my short brief of what the talk will be about, aside from thinking about what that experience will look like for that medical student. I'm going to detail time trends and findings from 2 national surveys of Muslim American physicians, particularly around the prevalence and predictors of religious discrimination. I'm going to describe experiences with religious discrimination at different tiers, patients, colleagues, and supervisors, as well as institutional experiences. And then we're going to discuss impacts of such experiences upon the psychological and professional ramifications for these physicians. Lastly, I'm going to detail some recommendations to improve the workplace climate and advance healthcare equity. So to do all that, as Adil suggested, is a research data-driven sort of institute, we're going to talk about these data sources. So in 2013, we led a national survey of Muslim physicians, which is a random sample of physicians from the Islamic Medical Association of North America. And we did this because of what Meyer pointed out, that healthcare databases and even healthcare physician databases like the AMA master file do not include religious affiliation. So you cannot use these national administrative databases to get at a sample of Muslim Americans. That's why we use this professional organization, which basically our survey was over 33% of the paid membership. In 2021, we did another national survey just recently in the pandemic and included some interviews, again, going back to Imana, but also extending the sample to 2 other physician groups, organizations, the AMHP and US Muslim Physician Networks. And then for interviews, we selected a subsample of those who responded to the surveys. So just generally speaking, you should note that the inclusion criteria for the survey was individuals had to be English speaking, practicing medicine, so not retired, self-identified Muslims in the United States. And in 2021, we drilled down and wanted to get a sample of individuals who had worked at or were working at presently academic institutions in the United States. So what was the population? So note that in 2013, our sample was about 255 physicians, in 2021, 264. And in this graphic, I'm just laying out basically, and for those who want more detail, we can look at the policy report and the papers that are coming out. You can reach out to me, but basically the sample was somewhat different in 2013, 2021. So in 2021, the sample was a little bit more young, right? So they were younger than the one in 2013. That also means that they've practiced, right, less years than the one in 2013. Predominantly in 2013, our sample was mostly South Asian, but you'll note here that in 2021, we had a much more diverse sample of participants. So Arab, South Asian, as well as white, Caucasian, and Black African Americans in the sample. And again, because this was a younger sample, most of them had been born in the United States, as opposed to the sample 2013 that mostly was immigrants. So that's kind of the idea, right? The 2021 a little bit younger and a little bit sort of less practicing in medicine, meaning they had less years of practice, while in 2013 they were older. In terms of their religious practice, another sort of important thing to think about before I get into the specific details was that in 2013, we had a mostly Sunni sample, but in 2021, we had a more diverse sample of Sunni and Shia Muslims, right? And this sample was also less religiously inclined in 2021. So you see, in thinking about whether religion is the most important part of their life, over half the sample in 2013 said yes, but here more diversity. Same thing about attending religious services. Yet, in terms of their appearance, right, more physicians in 2021 were wearing a beard, men, or wearing a hijab as women. So they're more physically, visibly Muslim. All right. So now let's move on to what did we find, right, over the time course. So in 2013, about a quarter of physicians reported having experienced religious discrimination over their career course. That number more than doubled in 2021. So over 50% of individuals in our sample said that they'd experienced religious discrimination over their career. What does that look like, right? So obviously, this has to do with kind of the impact of discrimination. So let me kind of talk about the tiers of discrimination. So they can occur at different levels, right? From colleagues or others. We can have some demographic notions of that. I'll share with you what predicted discrimination and then the impact. So where does it occur? From patients, colleagues, leadership, and also the perception of lack of accommodation of their religious observances is perceived as discrimination by this physician group. The demographic predictors, so let me pause for a moment here. People who go into the profession in 2013 who felt that religion is very important to them, they were more likely to have experienced discrimination currently at their workplace, and experience more job scrutiny, and having more difficulty to pray at work. In 2021, because we had a more diverse sample, we found that African Americans, right, reported more discrimination or experiencing more discrimination than the other groups within the Muslim sample. Yet religion now had a two-sided effect, right? So those who had greater religious practice, right, mirroring more prayer, more individual prayer, that protected against discrimination, meaning that they reported less discriminatory events or less perception of discrimination by the workplace. But yet they were more likely to leave their jobs. And those who felt religion was more important to them, right, that was associated with the greater experience of patients refusing their care. Now, these are finer points from multivariable analysis. I can speak to more of that in the Q&A, but I want to share that with you, that there was a much more sort of diversity and finer nuance within the 2021 analysis. The impact of this occurs at the psychological level, at the professional level, and the personal level, and I'll share with you some details in a few moments. So as I said, Muslim physicians over time are increasingly experiencing religious discrimination in the healthcare workplace. There's an example from patients. 9% of our sample in 2013 said that patients had refused their care because they were Muslim, meaning the physician was Muslim. This jumped to 33% in 2021. And statements like this, they would report from patients. How do I know you're not ISIS? Or how do you know that being a Muslim, you're really treating me and not actually trying to harm me? From colleagues, most often this was thought about in terms of how they would interact in their daily practice. So this is an example of a coworker action that was perceived as discriminatory. So I'm scrubbing into the OR, there's some nurses who would give me a hard time about wearing a long sleeve shirt under my scrubs, or a hard time about wearing a hijab, so from their colleagues. As I mentioned, from leaders, non-action, non-accommodation was perceived as discriminatory. So this is a participant, right, our female saying that most of the events on campus, meaning at our workplace, contain alcohol. They don't cater for my dietary choices. In terms of practice now, both surveys show that individuals struggle, and Muslims have to pray 5 times a day. They struggle to pray at work, right? So 50% in 2013, 44% in 2021, no real statistical difference there. And this is an example, right? So they would get 1 lunch break. If I get a lunch break from 12 to 1, I can go pray. Otherwise, I struggle to find time in the middle of a busy clinic. There were other practices in terms of their religion that they also struggled with. So this included Ramadan fasting. I described daily prayers, and I'll give you a little bit more detail there, and Friday prayer service as well. So here's an example from a participant about Ramadan. They would ask the supervisor, this is going to be Ramadan from this time to this time. Can you put me on an easier rotation? Some years it would happen, some years it doesn't. So Muslims are fasting sometimes a few years ago when the days are long, 18 hours a day, asking for some accommodation in their work schedule that would be unevenly received. In terms of daily prayers, I want to note here that those trainees found it to be much more difficult to bring this up to the supervisors. So this is a quote: when I was a resident or a medical student, I would not be vocal enough to say I have to go pray, fearing that they would then be marked or seen as less of a high-performing student as others in their rotation. With respect to Friday prayers, here's an example of a quote that coworkers question why I take 2-hour lunch break for Fridays. And this participant told us that then their supervisor had to explain, right, why they were leaving. And so he felt sort of uncomfortable with that open conversation with their colleagues. The other big thing is that when the religious identity of physicians is not accommodated, they perceive that discrimination and they wonder why. So let me share with you what types of sort of identity are inadequately accommodated by the healthcare system. Diet, their religious holidays, and dress and appearance. Here's an example of a quote about diet. So this individual said, I emailed that program administrator a spreadsheet of dietary restrictions for all the people in their work group. And that program administrator said, people can just bring their own lunch from home if they can't eat what we provide. They weren't creating an inclusive environment for us. In terms of holidays, one of our participants sort of said, I worked Christmas for 7 years, but I never had coverage for Eid, which was his religious holiday. And in terms of dress and appearance, some individuals decided to forego these religious observances, saying that a beard would draw more attention, therefore they decided to shave it off. So the ramifications of this are that Muslim physicians across time span increasingly perceive being passed over for professional advancement due to their religious identity. So in 2013, again, about a quarter of participants noted that they felt that they were passed over possibly or probably for promotions or other advancement opportunities because they were Muslim. This number jumped to over 50% in 2021. Here are some examples of quotes from our participants. Right? It came to a point where my juniors were being given those administrative positions. These positions were not advertised or anything, feeling like she was seniority-wise, as well as being a Muslim, not prioritized. Another example of leadership, right? You don't see us, meaning Muslims, on the ladder at all in leadership positions. It's very rare. Most of the time, people who step up to that ladder are far distant from the Muslim community. So there was no one to look over to or idolize. They were all kind of stuck in middle management. So being marginalized or seen as a group that's outside the norm or receiving discrimination, and then trying to seek jobs in leadership positions but not getting them, has incredible impact upon individuals and their lives. So here's one example of that. Muslim physicians are increasingly leaving their jobs due to workplace discrimination. In 2013, 7% said that they had left their job because of religious discrimination. Again, that jumped to almost a third of the sample in 2021. Here's a quote, right? The discrimination escalated to a point where it was making me feel nervous. Things accumulated to the point where I had to change my job. In terms of psychological impacts, right? So Muslim physicians are experiencing depression, anxiety, and burnout. So here's another few quotes. Many of us, Muslim physicians, end up sustaining these microaggressions. It's an emotionally difficult thing to do over the career. Individuals created a hostile work environment for me. I was close to having a nervous breakdown, was another participant saying. In terms of a objective measure, about 29%, so this is here, right? Some symptoms of burnout. 29% say that they were feeling some degree of burnout, had one or more symptoms of physical, emotional exhaustion at work because of related to religious discrimination they encountered on a daily basis. So as a summary of what I just presented to you, right, over 10 years of work, here are some implications of that. So we know that Muslims in medicine, that religion, they're drawn to the profession because of a calling, a notion of religious calling, but oftentimes their identity becomes a mark against them. The more important religion is to them, the more challenges they face, and they have an increased risk of depression in this 2021 survey. Prayer activities offer a buffering effect, something that our findings echo what Myra just presented from ISPU's work. But the larger scope issue is that if some types of physicians, be they Muslim or non-Muslim or whatever group they are, they face discrimination or disincentives to work in certain environments, then high quality patient care will suffer, less concordance, right, less outreach to minority communities, and social equity is not advanced. So anti-Muslim sentiment is alive and well in medicine, unfortunately. Diversity and inclusion programming must extend programs and policies to cover religious identity accommodation. To that effect, our participants in the interviews gave us some ideas, which I'll share with you now. Here are the recommendations that they offered. So for the first and potentially the most important thing was daily prayer space. They want to have designated space to pray, right? Such as reflection or meditation rooms, not in a chapel with just like iconography, not in rooms for lactation rooms, right? Where often people would go in, or in stairwells to pray, rather a room, a place that they can pray, easily accessible to them during their workday. For Friday prayers, this is an established notion within the faith, but it's also a marker of identity. And so they want to be able to pray on Fridays, whether that be in the hospital and no questions asked, you can go, or outside of it, come back and make up the time. They need institutional support to do that. Oftentimes there would not be specific policies they could point to. In terms of Ramadan fasting, right, I already mentioned to you that this can become a grueling experience for some physicians, and as they age and have comorbidities, it can be even more challenging. We should know that and be accommodating that to adjust work-life balance, the work-life schedules for them, so they can do that. Some people mentioned to us that they would not break their fast on time, or they wouldn't even have time to eat their pre-dawn's meal, and then they would have difficulties while they're performing their work activities. Eid holidays, right? The two Eid holidays that are for Muslims should be acknowledged not only in calendars, but also no questions asked. They can take time off without enduring undue hardship. Dietary preferences is sort of self-explanatory, right? Oftentimes we have events with alcohol or no vegetarian or halal options, or sometimes we meet at bars. This is really difficult for Muslim physicians. They feel left out, and we should be more inclusive in that, right? Not only for Muslims, I'll say that I was at a recent event personally, and I know in my physician group there are individuals who are recovering from alcohol addiction, and they didn't want to come to that event because it was situated in a certain area. So we should be very cognizant of this. Dress codes and appearances, right? The hijab and beard oftentimes is a visible marker of being a Muslim, and it can be not accommodated very well, right? In the OR, for example, or while you're in a sterile procedure. And so they feel pressure to not have those observances, or the accommodations aren't readily made. For the overall climate of religious accommodation, they talked about having faith community liaison positions, right? Where healthcare systems should have a role of someone who understands the needs of their physician group and the community around religion, tailored and targeted interventions that are largely educational based for patients, staff, faculty, and trainees. And then really a focus on including religion as within workplace equity programs, right? As I said, they noted that often it was left out within that. So with that, I will end. And so we talked about that physician, that trainee who is going to be in training as a resident in a few years. She's applying for the match now. What we want to do is change from this quote from one of our participants, that being Muslim or visibly Muslim or a practicing Muslim is going to impact us in some negative way, to where your identity is included, right? They don't care what's on your head, but whether what's within it. So with that, I'll end. Thank you for your time. Let me stop sharing. Seconds. Sorry, hold on, the bar is not coming up.
Dr. Padella, thank you for this comprehensive review of your team's work. And again, the full report will be available on medicineandislam.org in the next few days. So now that the research has been presented to us, and we have an understanding of Muslim physicians' experience and some suggestions on how we move forward, let's now examine this framework and its application with our next and final panelist, Dr. Greer Jordan. Dr. Jordan joined MCW as the inaugural Vice President for Inclusion and Diversity and Chief Diversity and Inclusion Officer in January 2017. Dr. Jordan is responsible for leading inclusive excellence and innovation as an accelerator of MCW's strategic priorities and success, and its just cause of improving health for all, particularly those who encounter systemic barriers to health and opportunity. As faculty in the Institute of Health Equity, Dr. Jordan is faculty for research of early child development by improving resiliency and equity, and student-centered pipeline to advance research in cancer careers. She also serves as faculty in the MCW Kern Institute Kinetic 3 Medical Educators Training Program. She is PI for an AHW-funded healthcare workforce grant called Milwaukee Healthcare Workforce Initiative and the MCW lead in the Milwaukee Anchor Collaborative. Dr. Jordan, please walk us through inclusion and action at MCW, moving from compliance to belonging for people of Muslim faith.
All right, good morning still, everyone. Once I clicked my screen, everything changed, so I had to find my buttons again. I want to take this opportunity today to talk about maybe sort of the applied end of some of the things that we've been talking about already this morning. And I'm calling this presentation Inclusion and Action at MCW from Compliance to Belonging because there are legal compliance aspects around inclusion. There are legal anti-discrimination work that institutions are responsible for. Then there's the other piece about the culture change. And I want to put a bit of a disclaimer on before I begin that I work for the university side of a healthcare institution, but many of the things that I'm talking about are applicable to a healthcare setting and the requirements in a healthcare setting as well. And I'll try to flag some of those differences. So I'll cover three main ideas this morning. I'm going to start with MCW's vision and the importance of inclusion. I always like to put this in context of what we're ultimately trying to achieve when we talk about regulatory requirements, but also when we talk about what we're trying to accomplish in terms of culture change. I will outline how the religious accommodation process, and I will qualify with should work. I think it's really important for people to know how this process is supposed to work. When it starts to go awry, be able to advocate for oneself as to how to ensure that everyone has the accommodations that they need. And then I'll give some examples of some initiatives underway at MCW. So first, that larger vision here. So at MCW, when we talk about inclusive excellence, it's in the context of achieving this vision of improving health for all, but in particular, having a healthy world in which everyone has that opportunity to have the best possible health that they can and be able to thrive. When we think about this, the big picture, what are the costs of not including a diverse and talented healthcare knowledge force? I refer to knowledge force when we're talking about our health science institutions. So, of course, we know there are increased direct medical costs due to health disparities that are results of not having that diverse workforce. Worse access to care for underserved communities. We know that people of religious faith, people of different ethnic and racial backgrounds are more inclined to provide this type of care to underserved communities, both urban and rural. Lower quality of care for vulnerable populations. Healthcare studies have shown that patients generally fare worse when care is provided by more homogeneous teams. And then professional and skill-focused studies generally find a loss of improvements in innovation, team communication, and decreased risk assessment when we don't have people who are coming from different life experiences, different ways of knowing, different ways and connections to the students and patients and communities that we serve. So in short, a religious inclusion helps us work better together for health. So let's talk a little bit about religious accommodation in the workplace from a policies, practices, and procedures point of view. And these are the formal policies, practices, and procedures that any federal contractor, any institution that works with the federal government are required to adhere to, which is going to be the majority of healthcare systems out there, as well as particularly university systems. So Title IX is the regulation, and it outlines a regulation around what federal agencies require in terms of providing what's called reasonable accommodation to employees whose sincerely held religious beliefs, practices, or observances are in conflict with work requirements. And there is a caveat here, unless the accommodation would create an undue hardship. Now, I can say from looking at case law that threshold for undue hardship is pretty low for a large organization. The larger the organization is, the higher the expectation that a organization would be able to absorb this undue hardship. Important to the religious accommodation process is making the accommodation request. So that process starts with making the accommodation request. The trigger for knowing to make an accommodation request is if one is requesting something that's outside of regular work procedures in the workplace, things that have to do with scheduling, work conditions, all those types of things can be areas where an accommodation request might be needed. You don't have to say the magic words accommodation request. It just have to express there is a need and to start this process. The process should begin with gathering information. Generally, one would talk to one's work supervisor or manager, the person who is, for a student, maybe their preceptor or back to the program director to make that request. And that individual should be then working with a individual, either in HR, academic affairs, or if the diversity inclusion office has responsibility for this area of accommodation, but there is a designated person in those organizations who are responsible for being knowledgeable about different types of accommodation requests that could be made around disability, religious accommodations, any of those types of needs that employees might have that are not routine are built already into work processes. After that information is gathered, the next piece is to explore accommodation options. Choose an accommodation that mutually works. And again, that bar for the employer for what works is pretty low. I mean, employers have to have really, really great reasons for not making an accommodation, and it costs too much is not a valid reason. Implement the accommodation. And then the most important part that I see skipped a lot is monitoring that accommodation. And that's what makes this an iterative process. Well, the first accommodation might not work for some reason. There might be other pieces that have to be involved. There might have to be some education. Sometimes I've seen where the manager has to be brought along or peers have to be brought along. So it's important to look at this as an iterative process and be working with the person who can make sure that this process is happening. So tips to make this process work, and you can almost take these and flip it into challenges to the system. First is inquire. What office or function is actually responsible for coordinating accommodations? That can vary. For example, at the medical college, my office does not handle accommodations, particularly around any type of accommodation that is a legal accommodation. But human resources does. Or in some cases with faculty, it might be Office of Faculty Affairs. Finding out who this person is can be a challenge. I would recommend starting with your diversity inclusion office because even if we don't have legal responsibility in this area, we do interact with these different entities and can find out and help in terms of getting connection to the right person. In my office too, we like to make sure that monitor piece happens as well. So we stay involved that way. What is your order group needs core requirement versus what is a want? Being clear about, as clear as possible about what's needed is really helpful to the person who has to accommodate this recommendation. Sometimes they have to work through other obstacles. They have to work with particular departments. So the best information they have, the more likely they are to be able to come up with a accommodation that works. Sometimes it is necessary to have some documentation around this sincerely held religious beliefs. We particularly run into this around vaccines, but it is a possibility. So keep that in mind. Engage. It's an interactive process, both the individual and organizational needs, and particularly if it's a matter of safety. It's going to be prominent. There might be some additional costs. And arranging to have different things paid for, different services, maybe different laundry services, different clothing services, all those types of things are going to be part of that process. But make sure that's communicated and considered. And I recommend grace. So if we can go into, and it's important on both sides, the coordinator of the accommodation as well as the person asking, to practice that open-mindedness and curiosity. There are so many reasons why people might respond a particular way, et cetera, that has nothing to do with that particular situation. So we can go into the situation with empathy and grace. That really helps to make sure that the accommodation needs are met and the process goes as smoothly as possible. Did the accommodation work or not work? Let the coordinator know if the accommodation's not working. Go back. That is that person's role to follow through. But I will say, from working now across 3 different higher education institutions, your HR functions or even your diversity inclusion functions can be not as well staffed and a little overloaded. So it is helpful to follow up. And then lead, form or work with an employee resource group or councils towards some of the universal changes that I want to talk about next. So we have an accommodation framework, which is that a legal accommodation framework around this iterative process and making sure that individual needs are met. But we also have this idea around institutional change, where we're going to get the most impact from inclusion in organizations, so we can hit that sweet spot on this chart around inclusion. Why? Because when we are practicing inclusion, it's not just about a particular religious or cultural or ethnic or racial difference that a person brings so the institution can check the box that we're there. It's also about that sense of being treated as an insider, having that efficacy, being empowered to do the work that we're here in the institution to do, and do it in an environment where we feel like we have colleagues and support. That's where we get the most. That's where we get the most impact around inclusion. That's where we have that adaptive space, that innovation space, that engagement zone. So in terms of MCW, some of the things that we're doing is integration of equity, diversity, inclusion for excellence and integration into the strategies. And I'll show you a quick example of that in a second. We use the annual goal setting process to encourage measurable action with our top executives. Implementation of no group meeting days. I'll hit on that here shortly. Identification of prayer and spiritual places for students, faculty, and staff. Identification of group prayer space when the group was displaced from another space in one of the other clinical systems, working toward finding that new space. Education on tools for inclusion, religious calendars, the the communication around the avoid meeting days, the dietary needs through multiple challenges. I call it lather, rinse, repeat, because in a large organization, it could take a while for the message to get get across and people to start to change. Sometimes it's habits around how people do things that have to be changed. That understanding of professionalism and the anti-harassment process. And then for our students, infusion of health equity into the new fusion curriculum, instead of bits and pieces of knowledge about different groups, their needs for belonging, the patient understanding piece as well as the professional or understanding, infusing those throughout the medical school students' education and career. And also we're working on our basic science students as well in terms of having that type of professional literacy, competency, and humility. This is just an example of our inclusive excellence scorecard. Lots on here, just to give you a sense that we put measurable top-level goals around these initiatives. Just some examples of tools for leaders and colleagues to build inclusion. There is a seasonal celebrations guide that talks about the dietary restrictions. When you're going to have a celebration, have accounts for what the needs of everybody are in terms of participating. The interface days with work restrictions, so that managers know and understand in advance that some of their folks could need accommodations for certain days, and these are the days, and start to prepare and think about it ahead of time. This is the recommended practice being modeled by the President's Office as well as the Provost's Office here at MCW. It's a core list of religious observance days that have been identified for no group meetings, no large meetings within departments. And the President's and Provost's Office is taking the lead on modeling this, and as we work to permeate this through the organization. So just to conclude, I've laid out the process. I've kind of laid out a bit of the ideal state and how things should work. But of course, getting change in organization across all levels can sometimes feel impossible, but it's impossible until it's done. So there are people within your organization who are not only responsible in terms of their job responsibilities for helping, but also ways of just with this forum and the information that we're talking about here can really start to take that forward and make changes in our work environment, so those statistics that you saw earlier can be a thing of the distant past. So I will find out how to unshare here.
Dr. Jordan, thank you for sharing these inclusion initiatives and processes underway at MCW. And I think we can all agree that the insights that you and Dr. Padilla and Myra shared with us today really demonstrates what our path forward needs to look like. So with that, I would now like to open the remainder of our time today to our audience members to ask any questions that they may have on what was shared. So please feel free to continue entering your questions in the chat box, and I will direct them to our panelists to field. So we do have a couple of questions, and I'll start with one. Panelists, how do chaplains help?
I'll start, but I'm sure that the others have some comments. So, as we discussed, or Ada discussed, right, intersection between religion and medicine, you have an amazing individual, right, or a group of individuals as chaplains who fit both worlds, right? And oftentimes they can see things, they can understand things that we might not, right, from a patient care lens as well as from a provider lens. And so I think they can be allies within this domain, particularly around religious accommodations, helping to understand what the issue at stake is, what the value underlying that is, and explain it in a vernacular that both the healthcare system can understand and the patient, or in this case, the providers we're talking about today, can understand and help make those accommodations and negotiations happen. I've actually seen that happen at some of my prior institutions where chaplains right? We're able to give voice to certain things and uplift certain things that people would feel that they can't bring to the leadership themselves, or help in this sort of deliberative process. I'll let my other colleagues here speak to other insights.
Yeah, I'll comment just from in preparation for this. I did talk to my colleagues over in the healthcare system in terms of Froedtert, and one of the things that Froedtert Health, and one of the things that they pointed out to me and asked that I really emphasize is the importance of identifying that coordinator. For Froedtert Health, it is that coordinator is within HR. It's the responsibility of that person who's coordinating the accommodation to involve the chaplain, to involve other the diversity inclusion office, whatever other structures are involved in the institution. If that person is adept at putting that team around, ensuring not only that accommodation, but looking for opportunities to maybe change systems and processes on an ongoing basis, then we can get much better involvement and tap the expertise of chaplains, for example, that are within the institutions.
Thank you both for sharing your insights on that. The next question I have is, does reasonable accommodation refer to equal paid time for daily prayers, Juma prayers, etc., availability of compensated time?
So again, I think that I'll chime in first. I got to stop this the next time you guys chime in first, but I'm sometimes uncomfortable with silence, so I apologize. So having unfortunately been an individual who's had to be in some of the, as an expert in some of these cases, I will say that the legal mantra is more than de minimis. If the healthcare system can say it costs them more than de minimis, then it is an undue burden upon them. And as my colleague here said, that sometimes larger healthcare systems, their threshold for that is higher than for smaller healthcare systems. But for example, in the case that you're saying, if an individual says, well, we would like to have, some time off, oftentimes the question is, well, can we cover that person's slot in the healthcare system by someone else, right? And does that, for our healthcare physician group, right, does that cause more than de minimis burden upon us because we only have 5 or 10 people in this sort of practice? And I've seen those cases where the healthcare system has to show just a little bit sometimes, but a larger system doesn't say, well, you have 100 physicians, that's not really an issue. So it depends on the context. I'll also say that oftentimes, again, as being a consultant in this domain, the idea of, okay, well, we're going to look at analogous cases, and then we're going to also think about, and if you're a good team, we're also going to think about what other accommodations you make. So in this case about prayers, they said, well, are individuals allowed to take breaks during work? Can they go to the bathroom? Can they go take a smoking break? Some people do. Can they go for lactation? And when that is also a policy, then I say, well, then what's the difference between that and 5 minutes or 10 minutes for a break for someone to go pray? And I've seen that again in court cases be brought up, right? What's different and analogous here if accommodations already exist, or another witness sort of says, I have gone accommodations for these other things. What's the difference between that? And oftentimes within themselves, right? So for Friday prayers, which is a bigger thing, they'll say, well, I'll stay later, I'll come in earlier, right? I'll have a negotiation with my own workplace about how to make that happen, as long as you're willing to work with me, right? Because this is a time I do need. So I want to give some general contours to that. I think it's pretty complicated. And as we mentioned, we don't have a lawyer here, but I'm giving insight from cases I've been called to be involved with, where there's 2 sides to the story, and it's really context dependent.
Yeah, I would add it could be state to state dependent. Different. When I was in Massachusetts, I would say that the Office of Civil Rights in Massachusetts was much more, they were much less tolerant of employer explanations around things. But you go to other states, they can be very employer friendly. So it very much varies on how people look at that bar of what the accommodation is. Candidly, I think the challenge in healthcare is if someone could say that this is going to affect patient safety or patient access to care, that's going to be a pretty strong argument. So that's why I think it really, I think it's important to where one is comfortable to start this accommodation conversation early and get a sense of what some of the barriers are. Do you have support of your immediate manager about it or not? If you don't, then you do need to take it to the human resources, the diversity inclusion office, who's ever responsible for putting that accommodation process in place. And then I'll be totally candid. If that's not happening in the institution, then you're having to make this choice about how much time do I put into this versus trying to find friendlier places, just to be very candid. I will say, talking to my colleagues at Frederick Health and Children's Wisconsin who are in this area, they do sincerely want to make sure that people's needs are met. So I would say the earlier, the better. And so that these work processes, scheduling and all that type of thing can be worked through in a situation where the employer genuinely does want to work out accommodation.
Dr. Padella, go ahead if you have something to add.
So I just wanted to share what you just said and kind of from our interviews. This can become very difficult for trainees and medical students, and also for individuals who are now applying for a job. I will tell you from our data that they are often forced to hide their identity, not ask up front, because they fear they won't get that position. They're not in a privileged space to do that. So they have these conversations after they've already secured their positions, and then they might meet resistance. So I mean, this is throughout our data collection over the last 10 plus years, that this is really a challenge. So having frank conversations is great, but I recognize, and I want to validate those on our call who say, well, yeah, I'm going to bring that up during my interview, right? And how am I going to do that? And so this is our push to say policies should exist. People can get access to them. They already exist. Hey, we accommodate. I'll give you a best practice example from not our country, but in the UK, where they say, here are religious accommodations for various groups, right? For Sabbath, for Friday prayer, for whatever else, up front on their HR equivalent at medical centers, so that people know that, you know, they have an embedded inclusivity and you don't have to worry about it when you're at that job interview. Anyway, I don't want to take too much time, but I wanted to voice and uplift the voice of our participants in this domain.
Absolutely. We find the same thing around disclosing race, disclosing disability. It could be so difficult to decide what to disclose up front. In theory, this information, particularly like race or ethnicity information, is supposed to stay blind within the process until you get to the interview. For disability accommodation, sometimes a person has to ask because they literally have to have some sort of accommodation in order to get to the interview. But you're right. It is fraught with you never know. Looking at the sites is a good idea. That does remind me, like, one of the things that we came out of the last engagement survey is that people don't see this transparency about some of the things that I talked about here, getting that on the websites, getting that available. We have an intranet versus an actually, sometimes you don't see this stuff until you're on the inside. But yeah, I agree. Definitely not minimizing that challenge at all.
Madeline, I also wanted to chime in. I'm looking at all the questions in the box and listening to my very smart and esteemed colleagues here. And a couple of thoughts come to mind from our research that are sort of on a bigger level. So I apologize. This probably won't help many of the individuals who are really struggling with very real issues. I kind of want to acknowledge that they are real issues. So one of the things that we do through our American Muslim polls, which we've been doing since 2016, since 2018, so for the past four iterations, we have been measuring what we call the Islamophobia index. Now, the term Islamophobia, we could debate all day, but that is what we call our index. And it's based on the esteemed work of Dr. Emile Bruneau, who sadly passed away. But he was a neuroscientist who looked at conflict. And our index measures the endorsement of anti-Muslim stereotypes and tropes, things that are very common in our country and pervasive around the world as well, to sort of measure people's endorsement of those tropes. We've also measured bullying in schools and other sort of examples of religious discrimination, bias, and hate. And what we've found through all of this is that Muslims experience high levels of this, that anti-Muslim tropes are quite common, and that unfortunately there is a link between people who endorse these anti-Muslim stereotypes and tropes and their tolerance for policies that harm Muslim communities, that there is a higher sort of tolerance for authoritarian or other policies that harm the community when people are endorsing these tropes. Now, that's not rocket scientist, but it is proven. And so a lot of the questions I'm seeing are individuals who are sort of trying to fight a really big system of anti-Muslim bias and hate, and other groups absolutely have to deal with this as well. So that change on the systems level is really, really important. And I think so many things that my colleagues have mentioned, one, having a champion within the system, whether that's the chaplain or somebody in the HR office or somebody else, it's very difficult to fight some of these things on your own. It's very helpful when there's someone within the system who is helping you do that, and helping a group do that. I think another question in the Q&A was about, do you have any examples of systems that have done this well? And I want to acknowledge what an important question that is. Actually, some of the methodology we use at ISPU for some of our research is called appreciative inquiry, or there's also other methodology called positive deviance. But in these cases, what you're trying to tease out is what works. What systems have worked for people? What are the elements in those systems that have actually given better experiences? And how do you then reimagine these spaces based on what the impacted people are saying has worked for them? And I think there's more need perhaps in this setting to do that kind of research if it hasn't been done already. Or positive deviance, looking at a system and looking at that one place that has done something really well and trying to figure out why are they different from all the other, examples in the system, and what can we learn from that? So I just want to acknowledge that everyone's challenges are really real. It's part of a larger context of anti-Muslim, discrimination and bias, and that we need to look at it at a systems level beyond sort of the individuals trying to fight some of this stuff.
Yes, and I want to follow up with another question. How are physicians and student physicians to embark on the process of reporting without fearing retaliation? You all speak to, there are two levels to this, and I think this question captures it quite nicely. The micro or the individual relationships that you have with either a supervisor or your teammates, and the macro that comes from the institution's policy. How do you embark approaching each of those levels?
Yeah, and I guess I'm going to comment, just on this earlier piece. I think where we're kind of getting at is two levels. How do we actually have the environment and the climate change, and then what do we do in the meantime? So I spoke to some of the individual empowerment pieces, but let's talk on the systems piece for a minute. From my perspective, that's why it was so important to do two things. I'm on every executive level search committee at MCW over the last 5 years that I've been here. And one of the things I'm looking for is leaders who have this awareness of and commitment to the need to understand people and include folks from different backgrounds. That's the slow boat to change, but I truly believe until we not attack, but really look at the leadership level and get to that critical mass of leaders at all levels of the institution who are committed to this. You can have anything you want on the books, but if the leaders don't see how this is comparative to what the institution is doing, we're going to keep having this conversation over and over and over again. Also at MCW, these inclusion initiatives, inclusion and well-being initiatives, the response to our latest pulse survey is part of the executive measures. So that gives another level of attention to things. So I just want to talk to, it's a meeting, multi-level piece there.
So let me chime here for some kind of practical, experiential sort of data, again, from cases and patients and participants as well. So I'm going to give you a story where there was one institution where for a medical trainee, where one of the deans had spent some time, I think, as a sabbatical or as a visiting professor in Egypt and a medical school. And so what he did was when he came back, he noticed he spent, I think, Ramadan there or something like that. He noticed all these accommodations that happened for the students, right? When they were facing Ramadan, they had to get up at 3 a.m. They changed the sort of the timing of schedules of exams. So he came back and he wrote a letter and put it in a policy. It was the Dean of Student Affairs, I believe, and sort of said, Muslim students, right, at our institution, know that if you reschedule your exams in Ramadan, I understand, and we're going to make that happen for you. Right, or so on and so forth. And he became known in that medical school in a major city as someone who was leading this sort of institutional change, where he understood now what the challenge would have been for his students, and the students had never spoken up, right? But now you had an ally within the institution, versus another institution where the student themselves had to go on and sort of get accommodations or not get accommodations, and what they did instead was partnered with another way with a major local council of Muslim organizations to endorse a letter. And then that letter was copied and sent to all the neighboring medical schools saying, this is a group of religious leaders are talking about what you can do to make your experience better for medical students who are Muslim in this month of Ramadan. So those are two different strategies, right? But I know they existed at these major metropolitan institutions in different cities to make it not just this one-off, right? And I said, as I started in the other comment, I understand, I've experienced, I've been there where it's very difficult to do that. Just as a side item, people can do this. When I was interviewing for residency as emergency medicine resident, I made clear that I was going to not work 3 Fridays in a row. And I didn't want to be matched. I did that because I knew how important it was for me, and perhaps that affected where I ranked or who ranked me. But I did that because it's so important. I didn't want it to come up after the fact, right? That this resident needed accommodations for. So I'm not suggesting that as a strategy, but that's, right? It's just very difficult for individuals at times to do that. So that's my advice for medical students and trainees. I'll say something else. So having talked to the EEOC, residents are not our employees under the law. So all the legal accommodations that were suggested by Dr. Jordan here, they all apply. Medical students sometimes a weird space, but for residents, no. So all, Title VII, all these things apply, and you can find allies within, and I don't say go to law, within those policies that cover employees for yourselves as well, as individuals who are, yes, still training graduate medical education, but you're considered protected by those same laws. So, and finally, the law is not where we need to go. That is a poor arbiter as emphasis, right? To solve everything by law. But what I am suggesting is that you have some place to go to when there are no other recourses.
And I think we have time for one more question. Are institutions calculating the costs for diversity and inclusion? And are there reports available for review? What could be some of these resources?
I confess I didn't quite follow the question. I wasn't sure if the question was about what are the cost of like the diversity inclusion office or the cost of these programs, or if it's more like what is the cost of not having diversity and inclusion?
I believe the question is asking are they calculating the cost of implementing the programs themselves? And if so, are they available for, say, someone like you and me, or someone who may be interested in implementing a program in their university to view?
Oh, okay, I follow. So if they're so that if somebody wants to adopt the program, they have an idea how much it would cost.
Yes.
Got it. Okay. from my perspective, I find that the cost of implementing a program is more like people power. So staffing. So I think I alluded to sometimes your diversity offices and your HRs are a bit understaffed. That's been a lot of my work, is advocating for, a level of staffing, even of my office, to be able to properly pursue these things. I would say, um, at least look for that there's a true accommodations officer funded at the institution, and how much that individual is going to cost is going to vary from institution to institution. If that person has a legal background, you could easily be looking at the 6 figures. If that person, like a lawyer, like they're a JD or something, depending on the state. If they are more of like a paralegal or a very highly trained HR person, could be a little lower, but it kind of depends on the state. My experience has been more about having the people power than, supplies, materials, things like that you can say is, a program. How about you, Dr. Padilla?
So when we went at another institution to ask for certain accommodations, there was a question of what this would cost and where the funding would come from, whether the Muslim community would fund certain types of things. So simple things such as prayer rugs. Can you guys get a donor to do that, right? To bigger things, if you wanted to have a chaplain who would help, right, with issues of identity for Muslims, patients and providers or whatever, then is the community going to buy and pay for that chaplain? So I do think, again, like this is a very complicated and complex and nuanced conversation, right? And my point in sending this webinar is to show you that this community is suffering. They are not empowered, as some other communities are, generally speaking, right? Given the larger conversation and tropes that are happening about Muslims, and so therefore it's much harder for them to sort of do that. And then relying on individuals who are marginalized already to say, okay, then support your own programs, can become a problem, right? But when the legal says it's more the de minimis and the healthcare system is also going to cost us $100,000 to have coverage for Friday in this practice, then you have to come up with here's some other data to think about that as well. But I want to acknowledge it's complicated and nuanced, right? So I don't want people feeling here I'm not giving you tools. So the tools that we have given in this webinar are data-driven, a toolkit. These are the accommodations, and you should take this report, which will come out, and bring it to the desk of your diversity inclusion officer, to your HR person. Say, hey, look, this is what national data shows around Muslim physicians, right? But how can we partner to make this better place for everybody, right? But just note, right, this is awareness first. Know what's happening and what they're experiencing. And it is a high cost to the healthcare system and to patient care when they're not in that position. Sorry, I got on my soapbox there.
Amen. Oh, and don't even get into inside organizations who's supposed to pay for this. There's, even when they agree. So, having understanding what the costs are for the institution, what they can afford, what they can put in place, having a long-term strategy. Sometimes things can't be paid for that year, but maybe they can be paid for next year. So I think taking that longer term view, I like the idea of taking the toolkit, taking the things. It's like, let's start to lay out. Okay, can't pay for it now. How can we get a crosswalk or a walk in place to get to these things in a year, 3 year, 5 years? So much 3 years, 5 years goes by so fast. I mean, if we start to advocate for those things that are needed over time, I think we could be surprised where we are in several years.
And Dr. Jordan, I love that approach of advocating over time, because that to me sounds like a sustainable approach, which is really what we're looking for. And with that, I think we can wrap there. And I want you to all continue to imagine what's possible in creating healthcare workforces that we want to see, that are equitable, and continue building a world that embraces religious diversity. And I next want to thank our viewers for tuning in today and to each of our panelists for sharing their time and expertise with us. It's really between our audience and our panel and your willingness to participate in these conversations and do this work that allows me to see a productive path forward. And on behalf of Tanenbaum, I also want to thank the Initiative on Islam and Medicine and the Medical College of Wisconsin for including us in this meaningful project. And I also want to acknowledge the work of Dr. Badella, Dr. Azam, Yua, and the rest of the team. Really, without them, we would not have been brought together today. So I also want to remind everyone that in the next few days that the report will be available on medicineandislam.org. And if you registered for today's event, the report will also show up in your inbox. And with that, I want to wish everyone a great weekend and take care.
Take care. Thank you, everybody.